Hi, folks. Professor Gulliford here. It is Wednesday evening, and I'm recording some chapters for you. Monday is Labor Day, so obviously we won't be in class, but I don't want to get behind. So I am recording some chapters for you. It'll be chapter 3, which we started this week, but did not get to finish, and then case study 3. So that's probably all we'll do tonight, and then maybe get some more done over the weekend. But let's go ahead and do a screen share. Share sound, optimize video, and we'll find the PowerPoint for chapter 3 that we're, I think, about halfway through. Made some pretty good progress. I've got 3, 4, and 5 ready, but I don't think we'll get all that done tonight. So we're doing the share. You should be looking at conditions of the pleural membranes and pleural cavity. Just a reminder, the pleural effusion is fluid where it should not be between the lung and the chest wall. It's going to result in asymmetric expansion. That is, one side of the chest expands more than the other. Asymmetric fremitus. We'll talk more about fremitus here in just a minute. A dullness to percussion, absent or diminished breath sounds, and rubs, like a pleural friction rub. You'll be learning about that in your lab sessions. Yeah. Because blood and pleural fluids are similar, on x-ray they may look the same, and you may need a chest tube, which is officially called a thoracostomy. I had a student actually come to me after the board exam. She passed, but she said, "What on earth is a thoracotomy?" And I said, "Well, that'd be an incision into the chest, but I bet maybe the word was thoracostomy, which is a chest tube." Then it made sense. So thoracostomy is the chest tube that we put in. Excess pleural fluid can be removed by thoracentesis. Centesis is surgical puncture. Thora is chest. So we're going in with a needle, always above the rib, never below the rib, because of the nerve, artery, and vein, which are located there. So thoracentesis, which you'll also, be learning quite a bit about in lab. We're very interested in whether the fluid that comes out is a transudate, meaning it's clear, or an exudate, meaning it's cloudy. The transudate comes from some kind of failure, heart failure, kidney failure, liver failure, something like that. But the exudate comes from either infection or cancer. It's pretty much, one or the other. Yeah. Looks like an advertisement of some kind. So pleural membranes and the pleural effusion, this shows you a picture of where the fluid might go. Fluid tends to go down, air tends to go up. So in a pleural effusion, we're going to find the fluid usually at the base between the lung and the chest wall. And we're going to drain it out of there and then analyze it. Conditions of the pleural membrane include diffuse pleural thickening. And one thing that causes that is asbestos exposure. Asbestos, what a useful substance it really was. Oh my gosh, for insulation, for preventing fire, for flotation of ships. It was so useful. Nobody understood at that time, that would have been 1950s, 60s, that if it was inhaled, could cause terrible lung disease. And that's exactly what has happened. Asbestosis causes diffuse pleural thickening. So do some other things like chronic pneumonias and tuberculosis. But usually, if you would see diffuse pleural thickening on a board exam, that would be asbestosis. All right, tactile fremitus is the vibration when the patient speaks. So we have them say something. I have them say 99. I don't know exactly why we picked 99, but we did. And when you say that, there's little vibration that comes through the chest as you feel it. However, if there is a consolidation, let's see if that word would be here. There we go. Consolidated or fluid-filled area, then the vibration comes through more strongly. It comes through more strongly, and we actually feel a stronger vibration in the area where the consolidation is at. So it's very useful test and a simple test to perform. Fremitus is the vibration when the patient speaks, and it's stronger when there is consolidation or fluid. All through the body, we have osmotic pressure, oncotic pressure, and hydrostatic pressure, and they are balanced against each other. Osmotic pressure is the ability of a fluid to move from higher concentration to lower concentration. That's osmotic. Oncotic is where we have large molecules like proteins that draw fluid, draw fluid into solution. And oncotic pressure is very important in fluid balance. You'll learn a lot more about that as we move along. Hydrostatic pressure is the actual pressure, like a fluid column, or the blood pressure of the patient is hydrostatic pressure. And if that's too high, it actually pushes water out of the capillaries into the tissues. That's why you might see a patient with congestive heart failure that has very swollen ankles. We call that pedal edema. And that's what's going on, is too much pressure within the blood vessels. Lymphatic system is all the vessels and nodes throughout the body, and there are certainly a lot of them in the lungs. One thing I'd just be honest with you is say we don't see a lot of board questions about lymphatic system, but we're going to go ahead and cover the basics of it anyway. Lymph is a clear, yellowish, slightly alkaline, plasma-like fluid composed of water, fats, proteins, and ions. And the lymphatic system is constantly draining that away from the tissues. The lymphatics are important in that. When we have an infection, the lymphatics get busy hauling away the dead bacteria, and it plays a very important role. When the patient loses their lymphatics, and the example of that would unfortunately be breast cancer, where lymph nodes might need to be removed, then we will need to help them clear that fluid out that would have been done by the lymphatic system. So I won't go into a great amount of detail here, but just to say the lymphatics are very important. They're constantly working to clear up debris and get the fluid out of the tissues and back where it can be circulated and removed. I think we're going to show you a picture, yeah, there we go, of just how many lymphatics there really are. These are both lymph vessels and lymph nodes. I bet you've had swollen lymph nodes in your neck at some point when you had a sore throat or sinus infection or something like that. But they're all through the respiratory system, and you can see a map here of just how many lymphatics there are. There's a whole science called lymphedema therapy, which has arisen to help patients who have now lost their lymphatics. And it's basically a series of ACE bandages, which are wrapped around the patient in a systematic way to push the fluid up so that it can be better removed. Lymph nodes are all through the lungs, or all through the body, really. We have tracheal lymph nodes, tracheobronchial, bronchopulmonary lymph nodes, and you don't need that level of detail. Really, you don't as a respiratory therapist. But there are mapping charts that have been developed for these lymph nodes. And if we have to remove some, then we know where we're going to have to assist that patient in draining their lymphatics. Yeah. So let's see here. Very important for staging the occurrence of lung cancers. This is how we know how early of a catch did we get in the lung cancer, by knowing how many nodes, how many lymph nodes have been involved. We're hoping none, because then it means it is still a stage 1 cancer which has not spread and perhaps can be completely treated. So that will be helpful in your understanding of lung cancer. Moving ahead, we have two networks of lymph vessels. There is a superficial network, pretty much on the surface, sit right beneath the visceral pleura. And then there is a deep vessel network, which follows the route of the blood vessels and goes way down into the lungs. Both are important. The deep vessel network actually clears the lung tissue, the parenchyma. I think that's a word that we used last week in our lecture. A parenchyma is the actual lung tissue, the spongy lung tissue. The deep lymph vessels are enclosed by a covering of connective tissue, which also it's called the peribronchovascular interstitium, which covers the bronchi and the pulmonary arteries as well. I think that's really all you need to know about that. Moving ahead, the main direction of flow, initial lymphatics moves through the lymph networks toward the hilum. The reason the hilum looks whiter than the rest of the x-ray is because all these vessels come together there. We've got the pulmonary arteries, pulmonary veins, lymphatics, and the main airways. So the hilum of the x-ray is always whiter on both sides than other tissues in the lung. The first initial lymphatic area, the plate-like lymphatics, connects to the more pouch-like reservoir lymphatics, which then empty into what's called the conduit lymphatics, and they're more like capillary tube-like structures. This is a lot to know about lymphatics, honestly, certainly more than in my own respiratory school, but won't hurt you to know this. I have case study 3 ready for you. I had a couple emails today from students who wondered if we could get that in your hands sooner rather than later. That's a picture of all the lymph nodes in the lungs, and just look at all of them. They all perform an important function, and there you see the hilum, the area that I'm going around there with the cursor right now. That is the hilum, and you can see all the structures, lymph nodes, pulmonary vessels. Let's blow that up. Give you a little bit better view of that. In the center on each side. That's why the hilum looks whiter. There's a term that you'll hear probably pretty soon at the hospital, hilar adenopathy. Hilar adenopathy. That means that the lymph nodes and glands in the hilar area, that's in the center, are larger, more engorged than we would expect them to be. And that tells us something is going on that needs attention. That could be a cancer, it could be an infection of some kind, but it definitely requires attention. Conditions associated with lymphatic system, lymphangitis, which is inflammation. Any itis, as you know by now, is inflammation. Itis, inflammation. Lymphadenitis is infection. Lymphadenitis is infection. Adenitis. And then lymphedema is swelling. And that is what has led to the science. It's actually a specialization in healthcare today called lymphedema therapy. You can go get certified as a lymphedema therapist. And what you're doing is helping patients who have lymphatic problems. Maybe their lymphatic tissues have been removed due to cancer, but you're helping them to remove the pooled fluid from their tissues. I'm thinking about a patient right now who had a cancer that required a lot of lymph nodes to be removed in his leg, and that leg is constantly swollen until he gets his lymphedema therapy session, and then it's okay for a period of time, and then swells back up, and he goes for another treatment. But here's one of the biggest words in medicine: lymphangioliomyomatosis. What a word! Lymphangioliomyomatosis. It's a rare progressive lung disease, affects women of childbearing years, characterized by abnormal growth of smooth muscle cells, and cysts in the lung are what we characteristically see in this condition. I would call it LAM or LAM for short because that name is too long to deal with. But cysts in the lung, changes in the lymphatic system, and tumors in the kidney. So it is a bad disease. I've only seen a couple cases in my career. Sarcoidosis, you will see a little more often. Chronic inflammatory disease. We really don't know what causes it, but we get granulomas. Those are clusters of inflammatory cells in the organs and lymph tissues. Can affect any system, but predominantly the lungs and the intrathoracic lymph nodes. You will see sarcoidosis pretty soon, I would say. Symptoms may be nonspecific, may mimic other conditions. It's tough to diagnose because look at the symptoms. They apply to so many other things: cough, dyspnea, chest pain, night sweats, fatigue, wheezing, abnormal breathing, congestion, joint pain, skin rashes, abnormal liver function. Wow, how many things apply to that? But the diagnosis is made usually by biopsy. All right, this is a great little graphic. Unfortunately, little is the correct term because look how small the printing is. What I'm going to do is get you a bigger version of this that we can all actually read, and I'm going to put it in the course because it tracks the whole respiratory system all the way down through the lungs. And it is a useful little chart once we get it large enough for you to actually read. And in summary, the lungs are the principal organs of respiration located in the chest. The right lung has 3 lobes, the left has 2. There is no left middle lobe. That's been a trick question since I was a student. There is no left middle lobe. The mediastinum is the space between the lungs. It has the heart, blood vessels, esophagus, trachea, phrenic and cardiac nerves, thoracic duct, thymus gland, and lots of lymph nodes. Visceral and parietal pleura, very important. I'm going to highlight mediastinum because that's a kind of a key word for you. Visceral and parietal pleura. The visceral is on the surface of the lung. The parietal is on the chest wall. They work together, providing a natural pressure gradient that moves air in and out of the lungs. That's breathing. And we have an elaborate system of lymph vessels, lymphatic vessels, nodes, and tissues to provide drainage, filtration, and removal of unwanted fluid and contaminants. So there we go. You've survived chapter 3. What I did want to do is cover the case study because you may, you guys are Johnny on the spot getting this work done. You may want to go ahead and do this. It wouldn't actually be due until a week from this weekend, which would be, let me get the calendar out here. It's not due for about 10 days is what I'm saying. But you may want to go ahead and just get it done. And you are certainly welcome to do that. I check the grade book every day. I want you to know that. Every single day I go in there and whatever's there to grade, I grade it because I want you to have prompt feedback on, everything that you're doing in the course. This case study 3 won't actually be due until the 7th of September. So you've got plenty of time on that. But let's go ahead and tell you about it. 24-year-old male brought to the ED after a bike accident. He is slightly disoriented, indicates that he is having pain on the right side of his chest and difficulty breathing. Witnesses told the paramedics that they saw him riding in a bike lane, appears to have hit something and then flipped over the handlebars of the bike, landing on the concrete curb. He has decreased breath sounds on the right side. That's important. His vital signs are as follows: temperature normal, 37 centigrade is normal, heart rate 114. He's in pain. That's probably to be expected. Respiratory rate 23, a little fast. Blood pressure pretty high. He may be under stress right now. Oh, his pulse ox is 88. For a healthy young man, oh my gosh, it's 88% on 100% oxygen. So he's on pure oxygen and he's only satting 88%. This is not good. The emergency department physician suspects a pneumothorax and has formed as a result of the trauma of hitting the curb. So that's what the general public would call a collapsed lung. We call it a pneumothorax. We've got to treat it immediately. On your board exams, the word used is sudden. The patient has a sudden shortness of breath, a sudden onset of dyspnea, and that tells you it could very well be a pneumothorax. So what is a pneumothorax? How does a pneumothorax typically appear on a chest x-ray? And how would the pneumothorax be treated? That's your assignment, should you choose to accept it. Well, I guess that's a Mission Impossible line. But I guess by taking this course, you have to accept it. But if you would answer those 3 questions and submit them just the way you've been doing, you will succeed on case study 3. There are a bunch of case studies, and that's good because you're not just learning the anatomy and physiology, you're actually applying it to patients, actual cases, So that's a great thing. That's all I have for you right now. I'll be back with chapter 4 and case study 4. I'm not quite sure exactly when I'll get that recorded. I might get it done Friday morning, actually. I have an easy morning Friday. So at any rate, we'll post this in the course. See you in class.